can send an email to the address that is communicating with you, and we will try to answer you through the email as well. With that, thank you so much for your patient listening, and I guess I'm not too late. Swati, over to you.
Yeah. Am I audible and visible? Okay. Can you give me this access to share my presentation? Yeah. So my slides are visible and it's moving. Okay. Yeah. Yeah. Assalamu alaikum and a very good afternoon to all of you. And I'm really thankful for that nice and kind introduction. And I'm also thankful to the whole organizing committee, especially Dr. Azhar, for giving me this opportunity. And I would like to make a, you can say, confession that this is first time I'm speaking on this topic. We do, as a endocrinologist, we do talk about a lot about different kind of tumors, especially in those small and tiny glands, including pituitary, sometime in thyroid, sometime in adrenals, sometime in parathyroid. But as an endocrinologist, diabetes, obesity, and thyroid disorders, they remains our bread and butter. And we don't look for, you can say, this precancerous condition or their risk for developing cancer in metabolic disorders. So this was a great learning experience for me to, you can say, how these things can, you can say, affect development of cancer in the patients of diabetes, obesity, metabolic syndrome. So in next 40 to 45 minutes, I'm going to talk whatever things which I could gather, and I thought it is important to discuss with the audience. And as you know that metabolic disorders and how to minimize it. Yeah, I think. So metabolic disorders and cancers, and what are the shared pathways and the dual benefit therapies and precision medicine in oncology. So you can say metabolism is something which we all have been taught since our class, you can say 7th or 8th in biology. It is the chemical reactions which is happening in our body to maintain the homeostasis, to drive our all the things which we need. So different kind of metabolic disorders, they are definitely there, and one of them is obesity and diabetes. These are two most common disorders we talk about. But if you look at from a different perspective, then definitely it's not only obesity and diabetes, but cardiovascular disease, neurological disease, cancers, and aging. They can also have a very important component of metabolic disruptions in their pathophysiology. And if there is something is there in the pathophysiology, then definitely that gives us a target for the development of, you can say, tools for the screening, staging, as well as management. The concept of cancer as a metabolic disease, they have very strong rooting in the early 20th century, and definitely this predates the discovery of oncogenes and tumor suppressor genes. And traditionally, we look cancer as primarily a genetic disease, which is driven by the mutations in the different kind of proto-oncogenes, tumor suppressor genes, and many times you can say epigenetic changes, which leads to uncontrolled proliferation. But there is an alternatively increasing and influential view which considers cancer as a metabolic disorders, which is rooted in the abnormal cellular energy and metabolism. And this concept has deep historical origins, and recently it has regained strong scientific attention and backing with the evidence in the recent decades. And the metabolic overview of cancer dates back into the early, you can say, 19th century. In early 90s, in the early 20th century, in the third decade of 19th century, a German scientist named as Otto Warburg, we all have must listen his name, and who has given this the idea of Warburg effect, where he observed that the cancer cells preferentially produces energy through anaerobic mechanism, with the conversion of glucose to lactate even in presence of adequate oxygen. This phenomena, which is known as Warburg effect, was puzzling because normal cells typically rely on the mitochondria for oxidative phosphorylation, which is much more efficient. Warburg, at his time in 1920s, he proposed that the mitochondrial dysfunction was the primary cause of cancer, and the genetic changes were secondary consequences of the disturbed cellular respiration. But for several decades, Warburg's hypothesis was eviscerated by the rise in the molecular biology, because there is, genetics has taken a central, you can say, place in the development of different kind of non-communicable disorders in preceding decades. And the discovery of oncogenes, tumor suppressor genes, DNA mutations, and in cancer cells that shifted the dominant paradigm towards cancer as a genetic disease. And landmark findings in the tumor, you can say mutations in P53, RAS gene, BRCA gene, they development of cancer. And as a result, you can say that metabolic alterations were often regarded merely as the byproducts rather than as a causative agent. They were taken as bystander of product of the mutations leading to different kind of metabolic disorders. However, advances in the biochemistry, metabolomics, and system biology have reviewed the interesting metabolic theory of cancer. And now it is evident that the metabolic reprogramming is a hallmark of cancer, recognized formally in the updated hallmarks of cancer by Hanahan and Weinberg in, you can say, the last one, I think it was in 2011. And this metabolic disruption, or you can say, disrupted, disordered metabolism is not only responsible as an individual, you can say, factor, but that also influence multiple other factors, which has been described by Hanan and Weinberg in their hallmarks of, you can say, cancer cells. And they're not only there is a problem with the disrupted glucose metabolism, but also there is lipid and amino acid and nucleotide metabolism to support the continuous proliferation, resistance to apoptosis, angiogenesis, and immune evasion. That disordered metabolism, they also play a very important role in these hallmarks of, you can say, cancer. And now many important genetic mutations are associated with cancer, directly affect the metabolic pathways. For example, if you take IDH1 and IDH2, that leads to production of oncometabolite, that is 2-hydroxyglutarate, which alters the epigenetic regulation. Similarly, the activation of PI3 AKTM TOR pathway that drives glucose uptake and anabolic metabolism. So these findings, you can say, they are bridging the gap between the metabolic theory and the genetic drivers, suggesting that they are deeply interconnected. As you can see on this, just a minute, there is pointer. So you can see that they are, deeply interconnected. You can see the cause and effect is difficult to tell, but what we can say at this moment that they are deeply, you can say, interconnected, and in bidirectional way. Genetic drivers, they lead to disrupted metabolism, and disrupted metabolism leads to problem in the genetics, leading to oncogenesis or the progression of this. And from a clinical perspective, viewing cancer as a metabolic disorder has practical implications. This is very important because the diagnostic tools such as FDG PET, which we use to look for especially the, you can say, spread of the cancer, the metastasis, they exploit the increased glucose uptake by the cancer cells, and multiple targeting therapies of that which is affecting metabolism, such as glycolysis inhibitor, mitochondrial modulators, and dietary interventions like ketogenic diets. They are actively being explored and examined to the conventional treatment. So, being an endocrinologist, I cannot refrain myself from talking about type 2 diabetes because that of our century, not only in this century but also the last century. In the last 2-3 decades of the last century, there was you can say exponential increase in the number of diabetic population in the developed countries. But the problem now is that the middle and lower income countries, they are seeing the most, you can say, they are most affected by the diabetes mellitus rise in the recent decades. So it is increasing day by day in our own country and in our own city. And definitely you can see this 589 millions, almost 600 million adults worldwide are having diabetes, and this is the most recent data published by the International Diabetic Federation just a few weeks back. And cancer incidence is, you can say, it is also increasing very rapidly, and we all are discussing different kind of theories about that, why it is increasing. And type 2 diabetes increases the cancer risk by, you can say, 20 to 40% across multiple cancers. And diabetes and cancer, they are interconnected through shared risk factor and the pathophysiological mechanism. As you know, type 2 diabetes is characterized by insulin resistance, hyperglycemia, increased risk of developing certain types of cancer. Notably, individuals with diabetes, they have very high risk of liver, pancreatic, endometrial, colorectal, and breast cancer. As you can see that the 2 to 8-fold higher risk of developing these type of cancer, and also breast cancer and bladder cancer. The risk of liver cancer is approximately doubled in patients with diabetes, partly due to non-alcoholic fatty liver disease, which we will see in coming slides. Pancreatic cancer is elevated due to problem in insulin production, stress, chronic inflammation. Endometrial cancer increases the risk because of hyperinsulinemia, which stimulates the cell proliferation. Because of insulin resistance in type 2 diabetes, in the initial years of diabetes, there is increase in the insulin production to overcome the insulin resistance which is there inside the body. So these, as you know, insulin is anabolic hormone. So that leads to proliferation of large number of cells across all over the body. So that definitely is going to increase some risk. The shared pathophysiological mechanism include chronic inflammation, oxidative stress. Oxidative stress is very, you can say, it's you can say one of the major pathophysiological mechanisms for development of different kind of complications of diabetes. And if you look at the epidemiology of diabetes, this is the most recent data which we have collected from Aligarh, in and around Aligarh. And this is the data. We do have data of more people, but they were more than 40 years. We have not included that in our this analysis. But you can see the diabetes in young, it is increasing very rapidly, especially in our country and more so in our region. You can see that this is a population-based study where we have included people from the rural as well as urban area. You can see that in patients, in individuals who are less than 40 years of age, diabetes was present in 15.2% of the patients. And pre-diabetes was also very high, it is 27.6%. So you can see almost 40% of our population has dysglycemia. And male and female, they were, you can say, equally affected almost. The reason behind this is multifactorial, but the issue with the young onset type 2 diabetes is that, as I was discussing previously, what are the shared mechanisms of development of cancer in patients with diabetes. So, the complications of diabetes, they are the factor of, multiplication factor of the degree and duration of hyperglycemia. So if a person is developing diabetes at the age of 60 years and he lives for next 10 to 15 years, so duration is quite short. But if a person is developing diabetes at the age of 30 and he has to live till the age of 75, for last 45 years, patient will be exposed to hyperglycemia and these problems. So development of complications will be very high. So this is hitting very early. Diabetes is hitting very early in our country nowadays, especially in our area. And if you calculate this ratio of diabetes to pre-diabetes, for example, from this data, this is more than 1. So if the data of diabetes to pre-diabetes is more than 1, that means that in next 5 to 10 years, we will be having a tsunami of young onset type 2 diabetes mellitus patient in our country, because these pre-diabetic individuals, they will convert into diabetes within few years. So we need to look into not only the diabetes part, but the other parts also. For example, as I am discussing today about cancer, so we need to look for those things and how we can prevention is always better than cure. So we need to look at the data, we need to look at the risk factors, and at least we need to apply some kind of, you can say, measures to prevent the complications, including the cancer. This is our another data. Here you can see, we have included, this is also population-based data along with our community medicine colleagues. So you can see that around 511 individuals. And so whenever I complete, my time is up, you just let me know so I can rush through these things. Total 511 individuals with first degree relative with type 2 diabetes. So any person who has got a family history of diabetes in the first degree relative, including the parents and first degree cousins. So here you can see the dysglycemia is almost 50%. So if you have any person in your family, immediate family, who has got diabetes, then risk of diabetes is very high. And if you look at the, you can say, less than 40 years of age group here also, so you can see almost a very good number of persons, they are also having pre-diabetes as well as diabetes. So even if we are young, and even if our BMI is not that much, but genetically we are susceptible for the development of diabetes South Asian. So we need to look into that. And persistent high blood glucose levels can lead to production of, as I have discussed, reactive oxygen species, leading to DNA damage, promoting to cancer development. Hyperinsulinemia, as I have already talked, that definitely they increase the insulin IGF-1, which is, you can say, an important growth factor for the cellular development. And furthermore, obesity, which is, you can say, chuli daman ka saath hai, obesity ka diabetes ke saath. We will see in coming slides that also. They also contribute increase of cancer through different kind of, you can say, pro-carcinogenic environment. So understanding these integrate relations between diabetes and cancer underscores the importance of integrated prevention. That's what I am talking, and we all should talk about this, because prevention is always easy and prevention is much more economically beneficial, and definitely this is a much more better outcome. And we should all emphasize lifestyle modification, regular screenings, and effective management of blood glucose to mitigate the crashes. All those who are listening to me, if you have a history of diabetes mellitus in your family, you should get your blood sugar checked as early as possible. Uh, so another very common metabolic disorder which we are looking in our population is fatty liver, which is technically known as MSLD. The previous nomenclature was NFLD, that was non-alcoholic fatty liver disease. Now this is known as metabolic dysfunction associated steatotic liver disease. So you can see, you can say fatty liver is very common nowadays. In fact, any person who has got his tummy protruded, so there the chances were very high chances of, I mean, almost half of the person with protruded abdomen, if they undergo some kind of imaging, you will find that there is steatosis. Good thing is that 90% of them, they remains stable. But the bad thing is that this is such, you can say the numbers are so huge. For example, if you talk about 101 million people of diabetes living in India, even if the 40% of them, 40 lakh, so 40 lakh people, they are having steatosis. And even if the 10% of them, they are going to develop SCC in next 2 decades, so we will have 4 lakh people with SCC in coming years. And this is the reality in the developed nation now. The most common cause of hepatocellular carcinoma is MASLD. Rather than previously, it was hepatitis C followed by hepatitis B. But now with the advent of, you can say, a very good vaccine, effective vaccine against hepatitis B, and very good screening of, you can say, blood products for hepatitis C, has almost, they are, you can say, very less number of patients of hepatitis B and C nowadays. But and even those who develop hepatitis B and C, we have very good antiretroviral therapy against them, so they can be cured. Now hepatitis B and C patient can be cured, and good thing about that is the treatment is available free of cost by the government across India. Even in our center, we are treating patients of hepatitis B and C free of cost. But MSLD is currently untreatable. We don't have any kind of, you can say, cure for that. And almost ultimately 7% of patients, if they land in hepatocellular carcinoma, that's a very big number. And metabolic dysfunction associated liver disease, this is very closely related to type 2 diabetes as well as obesity. And there is, chronic low-grade inflammation, as well as, you can say, insulin resistance, which promotes carcinogenesis in these patients. So, as a very high burden of NFLD, and almost more than 13 million people, they have advanced fibrosis. And if you look at the data of global prevalence of NFLD in patients with type 2 diabetes, 55%. So it's very high. And our South Asian region in India, you can see it is almost 57%, just second to the pancreatic, breast, and endometrial cancer, because these all are arising from the single, you can say, one of the very, you can say, baseline bottom line phenomena is insulin resistance and obesity. And hyperinsulinemia, altered adipokine signaling, dysregulated lipid and glucose metabolism, they lead to abnormal proliferation and impaired apoptosis of cells. So MSLD does not only represent a liver disease, but a systemic manifestation, hepatic manifestation of a systemic disorder with significant oncogenic potentials. And we should definitely look for the importance of early metabolic risk reduction for this phenomena, because it's very important to, you can say, save our population from these kind of things as early as possible. Okay. So now obesity as a risk factor for cancer, linked to multiple type of cancer, as you can see: breast, liver, gallbladder, ovary, endometrium, colorectal, pancreas, in multiple myeloma, and CA, stomach, as well as esophagus. Definitely, these are, the major, you can say, cancers which are driving the cancer mortality and morbidity across the world. So, excess adipose tissue, they promotes chronic inflammation, leading to hormonal imbalance. And obesity is, you can say, this is the one of the biggest pandemic of last century, and it is a recognized risk factor for not only diabetes, hypertension, but also of cancer. And the global obesity epidemic has led to increased incidence rate of several cancers, as we have seen. And data indicates 40% of the cancers in the world may be linked to obesity, more so in women. So pathophysiology of obesity and cancer is multifaceted. Adipose tissue, they secrete various inflammatory cytokines and adipokines. And these, they create a pro-inflammatory environment which is conducive to the tumor development. And excess adipose tissue, they also promote insulin resistance, as I am talking again and again about this thing in the diabetes, in the MSLD, and now in obesity. So insulin resistance is, you can say, a common denominator of many of the phenomena in these metabolic disorders. And especially obesity, especially the visceral obesity, meaning thereby the the obesity around abdomen is much more, you can say, dangerous than obesity in other parts of body. The reason for that is that the visceral adipose tissue, they are much more active in terms of secretion of different kind of adipocytokines, which often include the pro-inflammatory cytokines, and ultimately they lead to insulin resistance and increase in hyperinsulinemia, leading to increase in IGF-1. Along with that, there is oxidative distress and all those things. So this the hormonal balance associated with obesity lead to changes in cellular growth, and they can lead to problem in the differentiation, ultimately increasing the cancer risk. And it's not only that obesity can lead to development of cancer, but the prognosis of cancer is quite bad if the patient is obese. They often have more aggressive disease, high recurrence rate, and poor survival rate when compared there to normal weight counterparts. Obesity implicates cancer treatment by increasing the risk of surgical complication and negatively affecting the chemotherapy therapy efficacy. So we need a comprehensive studies focused on, you can say, weight management, physical activity, dietary changes. Especially obesity is now very common in our school-going children, so we need to take care of them. Childhood obesity is much more difficult to treat than the adult obesity. Obese child invariably turns into an obese adult. So it's very important to take these precautions early in the course of the development of obesity. We should watch the way I always, whenever I get a chance, I talk about this, the way we take care of their, their health, their education. So we should also take care of their weight. If it is increasing, then definitely we need to look into it. In the beginning, it's quite easy to handle. But once if the patient has developed obesity, then it's a self-perpetuating phenomenon, very difficult to treat. So everyone, men, women, boys and girls who are listening to me, you should watch your weight, you should watch your belly, and you should measure your waist circumference. And if it is more, you should take care of them at this moment only and start right now, because it becomes very difficult once you are having full-fledged obesity and its related complications. So what are the pathophysiological mechanisms? Here you can see the metabolic anomalies leading to different kind of things, which I have already discussed, leading to altered metabolic state, leading to problems in the DNA, you can say repairing, leading to more instability, oxidative stress, epigenetic changes. And all of them, they, you can say, promote carcinogenesis in some form or other way by promoting immune evasion and all those kind of things. Another thing where metabolomics can play a very important role, early identification of any disease, especially cancer, is very important, because if you are catching them early, your half job is done, because it's very easy to remove the cancerous part. It's the chemotherapy or the immunotherapy, whatever you are giving, they are much more effective in the initial stages. But if the same malignancy has, progressed to different parts of body, meaning thereby they have metastasized, then definitely you can say the risk is the prognosis is not that good. So metabolic markers, they offer promise for early diagnosis and also for risk stratification and prevention. And they can identify individuals which were primed for malignancy before genetic or imaging signs can appear. They serve as early warning signals for timely therapeutic interventions, and they enable restoration of metabolic balance to halt the cancer progression, and they highlight the translational potential of metabolism-based diagnostics and link to metabolic dysfunction with oncogenic signaling pathways. Just a small example of ALF10 and metabolic pathways is cancer prevention. You can see the hepatic transcription regulators connect lipid metabolism with cancer signaling. This ALF10 protects cancer against steatohepatitis via HNF4 alpha dependent lipid and bile acid pathways. They bridge the metabolic stress, inflammation, and hepatocarcinogenesis, which we were talking about. So we have got some practical example of that thing. So targeting a metabolic dysregulation offers preventive and therapeutic strategy. And early metabolic shifts may reveal novel tumor initiating pathways. And if you identify that, then definitely if we identify some kind of pathophysiology, then it's very easy. Not very easy, but at least we have something that we can target. So integration of the metabolomics into the genomics and proteomics enables precision prevention as well as precision treatment, which is, you can say, talk of the town nowadays, that is precision. And this is the same thing which I have talked. So metabolic dysregulation, inflammatory state, and other factors, they are the common pathological mechanism between cancer and metabolic disorders, which we have seen. And these are different kind of pathway which we have seen previously in the obesity, in the diabetes, that this phosphoinositol kinase 3, AKT, mTOR pathway, MAP kinase pathway, IgA bioactivity, and Warburg effect, where we have seen that there is, you can say that there is a basic change the way a cell behaves, especially with the bioenergetics, which leads to, you can say, their increased chances of survival, and less chances of apoptosis, and more chances of, you can say, spreading across the body. So these are the things which can be explained with the help of hyperinsulinemia. Along with that, there is inflammatory and metabolic diseases, for example, age, enrage, excess, this advanced glycation and products. They are very, you can say, basic, pathophysiological defect which happens in patients with diabetes because of increase in the level of glucose. There is increase in the glycation of different kind of proteins, and there is a receptor for these advanced glycation and products at the different cellular level. So this age and rage combination leads to epithelial transformation, tumor resistance, and epithelial dysfunction, which is responsible for multiple, you can say, complications of diabetes, including diabetic neuropathy, diabetic retinopathy, you can say, cardiovascular disease in diabetes, heart failure. So they are also implicated in development of tumors. And definitely we know that digestate pathway is one of the very important growth pathway. And if there is inflammatory cytokines, then there can be oncogenic gene transcriptions, nuclear factor kappa beta activations, which is, you can say, central to the development of inflammation. All these lead to angiogenesis and tumor progression. And metabolic reprogramming, both disease involve altered glucose, amino acids, and lipid metabolism. And this we have discussed already, that high risk for, you can say, pancreatic cancer, liver cancer, and colorectal cancer. And there is moderate risk for development of prostate, gallbladder, and obesity related, definitely post-menopausal development of breast cancer, endometrial cancer, cervical cancer. So these things are, you can say, quite, obesity and diabetes, they do play a role in development of these cancers in some way or another way. You can say they are basically complementary to each other rather than to compete with each other. They complement with each other. Now coming down to the therapies which we have at this moment. GLP-1 receptor agonist. This is something now everyone is talking about them. because they are, you can say, one of the most effective agents against the obesity, not only diabetes but also obesity. And almost 90% of the works of bariatric surgeons, they are done, because almost 30% weight loss can be achieved with the help of these GLP-1 receptor agonist or dual agonist against GLP-1 and GIP. And we have triple agonist, GLP-1, GIP, as well as glucagon. So they are in different stages of development, but the GLP-1 and GLP plus GIP, which is known as tirzepatide, GLP-1 receptor is semaglutide, which is available, and GLP plus GIP is tirzepatide. Both of them, they are now available in India, but quite costly therapy, at least 15,000 per month. But their patent will be off in March 26 next year. So a lot of, you can say, generic brand will be available at a very nominal cost of, you can say, around 2,500 to 3,000 per month. So they do have a very good efficacy against reduction of HbA1c, which is, you can say, one of the parameters which we target while treating a patient of type 2 diabetes mellitus. And weight loss, this is 3 to 8 kg, but more than 20 kg weight loss has now been observed, especially in those who are having, you can say, morbid obesity. And very good effect on cardiovascular events. They are cardioprotective also, especially the atherosclerotic cardiovascular disease. They are very much, you can say, effective in preventing them, preventing the adverse outcome in patients of atherosclerotic cardiovascular disease. And their preventive effect on this cardiovascular outcome is independent of their glycemic efficacy, meaning thereby, if you lower down the glucose by any other medication, and if you lower down the glucose with the help of GLP receptor agonist, and you keep both the groups on the same level of glycemic control, the cardiovascular outcomes is much more beneficial in patients who who will receive GLP-1 agonist when compared with the other kind of therapy. And because they are leading to weight loss, they are leading to, you can say, and there is decline in the pro-inflammatory state, there is decline in the insulin resistance, insulin sensitivity increases, and there is increase in the GLP-1 signaling on the immune cells also. So these things may have anti-cancer mechanism. And there are certain clinical evidence that from the observational studies, that there is almost 40% reduction in obesity-related cancer incidence if you use GLP-1 receptor agonist along with metformin. And definitely additional benefits, as I've already talked, they are there. Extra glycemic benefits, which we talk about them in our own terminology. Another is SGLT2 inhibitors. We have done some work with the SGLT2 inhibitors in carcinogenesis. We have got a very good animal data. Actually, I was not able to calculate that data because because of time constraint, but that work has been done in our university only, along with our basic science colleagues, where you can see that SGLT2 inhibitors, they are, you can say, that is sodium glucose co-transporter 2, which is present inside the kidney, the renal tubules, the proximal tubules. How they have anti-tumor effects, because they block the glucose resorption from kidney. There is less glucose supply to the tumor cells, and almost 70 grams of glucose can be excreted by the SGLT2 inhibitors. So cancer effects, they include GLUT1 expression. They will definitely have an effect on Warburg pathway, and they increase the AMP kinase activation, which is, you can say, one of the major, you can say, healing pathway in our body. And because of this energy crisis, because of decrease in glucose, there is decrease in ATP production, so that can increase the tumor cell apoptosis and will reduce to proliferation also, and that may also increase the chemosensitivity as well as radiosensitivity to different kind of therapies which can be given. And definitely there is benefits like weight loss, HbA1c, and they are very good drugs for, you can say, heart failure. And the management of heart failure has changed in last. Major pillars is this SGLT2 inhibitors. So they have got very good effect on heart failure, as well as in the patients who has got renal disease, not only patients who has got renal complication because of diabetes, but other kind of kidney disease patients, they are also being benefited with the help of SGLT2 inhibitors. So what if we combine both of them? So we do expect synergistic effect because they have got complementary kind of mechanism, because both of them, they reduce hyperinsulinemia, weight loss via different kind of pathways, and metabolic advantage will be superior HbA1c reduction and more sustained weight loss in long and short term. And definitely you can see that the cardiovascular benefits are much more with the help of GLP-1 analogs. If the patient has got atherosclerotic cardiovascular disease, and if the patient has got heart failure, then the benefits are more in patients who are receiving SGLT2 inhibitors. And definitely in renal patients of diabetic kidney disease or renal failure because of any cause, the SGLT2 inhibitors like dapagliflozin or empagliflozin, they are very effective in, you can say, reducing the risk of progression of the diabetic kidney disease. And definitely, so they are complementary to each other at different levels, and definitely they have potential for targeting multiple cancer promoting pathways if we combine both of them, especially if the patient is obese and have diabetes. Definitely, metformin is one of the wonderful drugs. Even after 60 to 70 years, it remains the first line therapy in most of the uncomplicated patients of type 2 diabetes mellitus because of reduction in hyperinsulinemia, reduced mitogenic effects, and cancer risk. And also there is reduction, there is AMPK activation. So there is reduction in this mTOR signaling pathway, which has anti-proliferative and pro-apoptotic effect. And definitely it is also useful in weight management as it promotes modest weight loss. And definitely it has one of the drugs which has got very good cardiovascular safety as well as benefit. So even we have tried a project of metformin in cancer cachexia, but we were not able to, you can say, convince the funding agency. But definitely we are trying to do something with metformin also in our university for cancer. So what is the final thing that now what we need to is integration and multi-specialty, multimodality kind of approach is needed in every disease, including cancers. So we need to have tailored therapy selection based on not only on glycemic control, but also on the weight, the cancer risk, the comorbidities in the form of heart failure, CKD, ASCVD. And we need to have regular monitoring to develop, to see the adverse effect of these drugs, and also to see the beneficial effects of these drugs. So what are the things which can change in clinical practice? Is that we should select anti-diabetic therapy considering the cancer prevention benefit also in long run. But for that, we need more, studies, as you have shown that metformin plus GLP reduces the risk of cancer resistance by 40%. But we need more data so that we should give the benefit of evidence-based medicine rather than based on our own judgment or our own thinking, because the era of evidence-based medicine is over. Now we should talk about the evidence-based medicine. Wherever the evidence is there, we should share with our patient, and we should try to give the maximum benefit, which is based on some logical reasoning rather than our own, you can say, comprehension of anything. And first and second and third line drug can be decided according to the patient's condition, patient's affordability, patient's, you can say, the comorbid conditions. And early intervention is definitely, we should try not only from the cancer perspective, but also from the perspective of development of diabetic complications. So there are multiple research opportunities in future. Definitely validate cancer incidence reduction with dual therapy. We need more mechanistic research, how linking the diabetes, obesity, MSLD, and cancer, how actually they are converging to one thing. And definitely we need more biomarkers, less kind of, you can say, less invasive, or you can say non-invasive or liquid biopsy kind of things, by which we can diagnose, we can characterize, we can prognosticate, we can provide the risk stratification based on the metabolic markers. And definitely therapeutic combination based on these things should be provided to our patients. So just to summarize my talk, metabolic disorders and cancer, they share the fundamental pathophysiological pathways, and we need to have strategic use of anti-diabetic agents, which offers dual benefit of optimal glycemic control and reduces the cancer incidence and mortality, have cardiovascular protection as well as benefits in the kidney, and they should improve the quality of life also. That is also very important. अगर जिंदा है तो जिंदा नजर आना भी जरूरी है. What happened? So that's all. Thank you very much for your patient listening. If there are any questions, then definitely I am happy to take those. I think there are no questions in chat box.
I think I'll read that. Yeah, sorry, go ahead.
So we have got, four kind of parameters. One is fasting, another is postprandial, third is random, and fourth is HbA1c. So if any one of the tests is above, you can say, above the normal range, then definitely we should start the treatment. And treatment does not only include the medication. The first line of treatment still remains diet and lifestyle modification. So any patient who has got HbA1c of more than 6.5 or fasting of more than 126 or postprandial or random blood glucose of more than 200, they should be started on treatment. And treatment may or may not include medication, because diet and lifestyle modification is as good as any kind of medication. So we tell our patient that this is the first and best and safest medication, and also the cheapest one. So any one of them, if it is abnormal, then we should go ahead with the treatment. You should consult your doctor and start the things as early as possible. And if you talk about the sensitivity, which is the most sensitive test, is you can say the postprandial glucose is the most sensitive, but you can say many times they are they are not reproducible. So HbA1c is also a good test in that scenario, that it gives us an integrated measurement, and along with that, there is no need for fasting to do an HbA1c. It can be done at any time. So every test has its own benefits, and you can say risk.
Can I take one question?
Oh, why not? I will be happy. Okay. If I'm not able to answer, then you have to give the answer also.
No, it's a genuine question. Yeah. I was just thinking about, there are some known mutations or which are known to cause cancer. Okay. Is there a way that we can change something at the metabolic level, whether through drugs or whether through lifestyle changes, that can mitigate the effect of that mutation or the effect of that gene? Because that will be something that will be crucial to understand that these omics are playing together, or DNA is the master regulator.
Definitely. This is something I think where the focus is now going on, that we should identify different kind of mutations, especially those who where the things are common. For example, if I'm talking about PI3 kinase or mTOR or MAP kinase, if these kind of things are activated in any cancer, then definitely, because these are the things which is also activated in different kind of metabolic disorders. So repurposing of drug is also very important. So definitely, maybe they don't have the curative effect, but at least they will have some kind of beneficial effect in terms of that they might increase the sensitivity of the kind of traditional chemotherapy or any kind of immunotherapy which we are giving to the patient. And definitely they might increase the sensitivity, they might increase the cure rates, they might increase the decrease the relapse rate. So all those things, I think we should, evaluate, because with the advent of these generic GLP-1 analogs, I think we should talk more about these therapies along with the conventional therapies which is available currently.
Right. Thank you. I think there's one more question.
So what? Basically, what we are talking about right now is not the risk reduction. It's basically, clinical improvement, because risk reduction is something which is in the primary prevention. We don't have data, that much solid and robust data for primary prevention. But if the patient has already heart failure, or if the patient has already renal failure, in that situation, definitely the risk of hospital readmission is almost reduced by 40 to 50%. Risk of mortality due to heart failure or any heart condition is reduced by, you can say, 30%. So they are, we can say, a very big boon. And one of the very important thing is that they are very, because of the patent is off now, you can get a SGLT2 inhibitor at the cost of, 6-7 rupees also per day therapy. And in patients with heart failure, there is also a issue of, you can say, low BP, hypertension. So they do not produce hypertension. They do not cause hyperkalemia in patients of renal failure. So definitely they are, you can say, a very good agent to reduce the risk of death, as well as the reduce the risk of hospitalization in patients with heart failure. And they are also very effective in reducing the proteinuria, which is one of the, you can say, hallmark of diabetic kidney disease. And they also reduce the risk of progression of diabetic kidney disease. For example, if the GFR declined by 5 to 10% per year, then definitely this decline is reduced to 1 to 2% per year. And the patients they are being prevented from the landing into the end stage renal if the patient has got heart failure, and if the patient has kidney disease, whether the patient is diabetic or non diabetic. Okay,
Actually,
thank
it
you.
will be a long break for the lunch. It will be 1 to 2, so we'll reconvene at 2. Is that right?
Okay, thank you everyone. Bye bye.
Thank you, Professor Hamid. I personally thank you for enriching the session and this entire course with your insightful lecture. Thank you.
Okay, bye.